Dr. Amer Karam attended medical school at the American University in Beirut. He completed his internship and residency at the Johns Hopkins Hospital in Baltimore, Maryland, a fellowship in gynecologic oncology at the University of California, Los Angeles, and a fellowship in breast surgery at the Memorial Sloan Kettering Cancer Center. Dr. Karam has a vested interest in minimally invasive and robotic surgery, with a practice centered on this approach for the treatment of patients and gynecological malignancy and complicated pelvic surgery. He is currently an associate clinical professor at the Stanford Hospital and Clinics and director of robotic surgery and outreach in the Division of Gynecologic Oncology. Ladies and gentlemen, please welcome Dr. Amer Karam.
Hi, thanks everybody for participating today and spending your time with me. I'm delighted to be part of this meeting this year. Although it's virtual, I'm sure it will bring you a lot of good information, and hopefully I'll be able to answer some of your questions and enlighten some of your or add to some of your knowledge in terms of what's happening in terms of novel therapies in ovarian cancer. First of all, just a little bit of background on ovarian cancer. As you all know, or probably most of you know, that ovarian cancer, although it's a rare disease and it doesn't even register in the top 10 cancers in the US, is still a very deadly disease. Unfortunately, most patients who are diagnosed with ovarian cancer will succumb to their disease every year. It accounts for about 14,000 deaths a year, making it the fifth most deadly cancer in women in the US. Some good news though, particularly over the past 4 or 5 years, there's been a trend toward a decrease in the incidence of ovarian cancer. It looks like we are seeing fewer cases of ovarian cancer overall. And the death rates have also decreased. Even though they are still unacceptably high, they are better than they used to be. This probably has to do or is due to a combination of several factors. We now know that some hormonal therapies can increase the risk of ovarian cancer, and we have seen a decrease in the number of women using hormonal therapy over the years. That probably accounts for some of the decrease that we see. Also, a lot of ovarian cancer are due to inherited or familiar predispositions for cancer. And many women now recognize this and are undergoing risk-reducing surgery that could reduce their risk of ovarian cancer. That's why we may be seeing fewer of those patients developing cancer, because they have their ovaries removed ahead of time. We've also become better more recently at treating ovarian cancer in terms of the additional therapy we can offer patients. And I'll go over that in a few minutes. It's clear that ovarian cancer is not one disease. There are many different subtypes of cancer, and they all probably arise because of different factors. By far, the most common ovarian cancer is what we call the high-grade serous ovarian cancer. That is the cancer that accounts for most of the deaths and most of the cases in ovarian cancer. It is characterized by this p53 mutation, but also it is often seen in combination with BRCA, or commonly known BRCA mutations, so BRCA1 and BRCA2. These genes are part of the homologous recombination pathway, and we do find that about 1 in every 4 patients with ovarian cancer carry a gene that predisposes them to this cancer along this pathway. The other less common types of cancers, including low-grade serous cancers, mucinous ovarian cancers, clear cell cancers, and endometrial cancers, have a different set of circumstances that lead to their development. They're much more rare and are treated somewhat differently than the more common high-grade serous cancer. This is currently the paradigm for treatment for a lot of our patients with ovarian cancer. Most patients, unfortunately, do not present until they have developed symptoms from ovarian cancer. At that point, patients are often diagnosed at the time of surgery. Sometimes patients, unfortunately, present with such advanced stage that surgery is not possible initially. And often we have to treat first with chemotherapy, followed by surgery before completing the chemo. Many patients, once they finish their treatment with chemotherapy, end up going on some form of therapy to make sure that cancer does not come back, what we call maintenance therapy. But unfortunately, many patients suffer from reoccurrence or progression of their cancer. Initially, the initial treatment phase takes about 6 months, and patients often spend about a year or so before their cancer comes back again, if it does come back. At that point, unfortunately, options are limited. We often offer these patients just chemotherapy. Rarely do we offer surgery again, but sometimes offer surgery to remove the reoccurrence of the cancer. But unfortunately, at that point, the die is often cast, and patients unfortunately suffer from one recurrence after the next before, unfortunately, the disease takes over and they succumb to their disease. Surgery for ovarian cancer is really very important, particularly in advanced stage disease. The reason why it's important is that it is often the best way to get rid of the majority of the cancer. And that's where debulking is very important. The goal of debulking is to remove as much of the cancer as possible, because we know that chemotherapy alone is not enough. And we often label debulking, or the goal is to obtain what's called optimal surgical cytoreduction or minimal residual disease. That usually has to be under a centimeter in diameter for most of these tumors. Ideally, we should be able to remove all of the cancer. So for us to be able to achieve this, often we have to proceed with a large surgical incision, an exploration of the entire abdomen, where all the efforts are taken to remove every single bit of cancer that we can see or feel. So often we have to do a hysterectomy, we have to remove the tubes and ovaries, we have to remove this fatty apron inside the abdomen called the omentum. We often have to remove the lining on the, or the surface lining of a lot of the internal organs called the peritoneum, and sometimes we have to remove enlarged lymph nodes. The goal is to take out as much as possible. My goal personally, and for a lot of the GYN oncologists and surgeons like me, is to leave as little behind as possible, ideally to remove everything that you could see or feel. This is a slide illustrating the importance of complete resection. On the right, you'll notice a curve, a pretty linear curve, linking the amount of cancer removed on the bottom to the overall survival of patients with ovarian cancer. As you can see, when 10% of the cancer is removed, the average survival is only about a couple of years. Whereas when 100% of the cancer is removed, the average survival is often over 4 years. So very important and critical step in the treatment for ovarian cancer. This slide just illustrates the fact that even though many patients present with advanced stage disease, cure is certainly possible. This is a patient of a colleague of mine that was diagnosed in 2009. She had stage 4 cancer with disease in the lungs, disease in the abdomen and the pelvis. She undergoes a surgery in early 2009 with removal of the tubes, ovaries, uterus, enlarged lymph nodes, as well as a chest surgery to remove an enlarged tumor inside the chest. She then completes chemotherapy following this very successful surgery, and she still to this day is alive without evidence of cancer, now 11 years later. Some of you may have heard of using chemotherapy inside the abdomen. This this idea came about because most of the cancer in ovarian cancer is centered and is located inside the abdomen and the pelvis. And often, even when the cancer comes back, it comes back inside the abdominal cavity and does not leave the abdominal cavity. The idea was to deliver chemotherapy directly into the abdomen to see if it works better than delivering it intravenously. In fact, we've had several trials comparing traditional chemotherapy to intraperitoneal chemotherapy, and they have shown in these first 3 trials an advantage to intraperitoneal chemotherapy. In this latest clinical trial that we published comparing IV to IP intraperitoneal chemotherapy, this was published in 2006 and it's called GOG 172. The researchers found that there was a survival advantage to using intraperitoneal chemotherapy. This led to the National Cancer Institute publishing guidelines showing that IP chemotherapy should now be considered standard of care for the treatment of ovarian cancer. The problem is this never took off because this chemotherapy is very harsh. It often is accompanied by a lot of side effects like neuropathy, pain. Patients often have to stop chemotherapy before they complete it because of the side effects. For that reason, the same clinical group that looked at, or research group that looked at this IP chemotherapy decided to do a more modern version of it, comparing more modern chemotherapies and a lower dosage of the intraperitoneal chemotherapy to see, 1, if it was more tolerable by the patient, and 2, if they could confirm the advantage of IP chemotherapy. Unfortunately, in this most recent trial, GOG 252, the prior results were not confirmed. And this led to a loss of enthusiasm in terms of the use of IP chemotherapy, mainly because of this trial, also because we now had a number of other developments and newer drugs that we can use in the fight over ovarian cancer that showed that could sort of even out the playing field in terms of the results of the chemotherapy and provided just as much of a survival advantage as IP chemotherapy did in the past. Now, still, a lot of us did not give up on the idea of delivering chemotherapy inside the abdomen. And herein comes the concept of hyperthermic intraperitoneal chemotherapy, or HIPEC. In this type of chemotherapy, the drugs are delivered inside the abdomen, often at the time of surgery to remove the ovarian cancer. They are delivered in a liquid that is heated, and the organs are bathed after surgery in this heated chemotherapy mix. And then the mix is removed entirely once the organs have been exposed to enough of the chemotherapy. Why HIPEC? One, the thought is that the heated fluid enhances the activity of chemotherapy by damaging the cancer cells directly and also increasing the permeability of the tissues to the chemo. So you're able to deliver a higher dosage of the chemo right then and there. 2, because this is often done at the time of surgery, you don't have to worry about scarring and malfunction of the catheters that often come with IP chemotherapy and prevent it from working very well. And 3, it's a much simpler treatment because you offer it just once and you don't have to keep doing it like we used to do with our IP chemotherapies. You don't have to worry about patients getting side effects because it's a one-shot deal. The enthusiasm about HIPEC was bolstered by this clinical trial. This is a clinical trial which was conducted in the Netherlands. In this clinical trial, all of the patients with advanced stage ovarian cancer started out by getting chemotherapy. They did not start out by getting surgery. They got chemotherapy first. So often these are patients with stage 4 cancer or advanced stage cancer that was so extensive that surgery could not be offered. So these patients started with chemotherapy to shrink down the cancer. Then they had surgery following 3 or 4 doses of chemotherapy, at which point, once the cancer was removed, the heated intraperitoneal chemotherapy was delivered. The patients recovered from the surgery and the HIPEC, and then went on to get 3 more treatments with chemotherapy. Now, in this trial, patients were randomized to HIPEC or no HIPEC at all. So half of the patients got the HIPEC with the surgery, the other half just had the surgery alone. And in this trial, which was published in the New England Journal of Medicine, there was a survival advantage to those patients who got HIPEC that was more than a year. On average, patients who got HIPEC along with their surgery lived for about 4 years after they finished, after they got their surgery, as opposed to 3 years, less than 3 years when they got just the surgery alone. What about the medical therapy for ovarian cancer? This is a timeline of the various agents we offer now for the treatment of ovarian cancer. And as you can see, a lot of these drugs on here are traditional chemotherapy drugs, beginning with the oldest drug that we've ever used that was specifically targeted toward ovarian cancer, which is cisplatin. This was way back in 1978. There was a long period of time before anything else was introduced that was specific for ovarian cancer until the cousin of cisplatin or carboplatin came on the market. This was followed a few years later by Taxol in the early 1990s, topotecan in the late 90s, and then liposomal doxorubicin or Doxil in the late 90s, early 2000s, and gemcitabine or Gemzar in the mid 2000s. Up until that point, all of the treatments we had for ovarian cancer were traditional chemotherapies. There was a shift that happened in the late 2000s. Starting in the 2010s, most of, if not all of the drugs that have been approved for the treatment of ovarian cancer are non-chemotherapy options. Basically, therapies that are either oral therapies or what we call targeted therapies that are designed to just affect the cancer and basically spare the rest of the body without the side effects that come with chemotherapy. One of the first drugs to be approved for that in this new era of chemotherapy-free agents is bevacizumab or Avastin, which was initially approved for the treatment and then for the in the maintenance or in the preventive space for ovarian cancer, but also a bevy of new oral drugs that are in the family of what we call PARP inhibitors. And this includes Olaparib or Lynparza, Niraparib or Zejula, and Rucaparib or Rubraca. So before we talk about these drugs, I wanted to just talk a little bit about DNA repair because it'll help set the stage for the next steps in my presentation. So a lot of the time, the chemotherapy and the radiation that we give patients, the way it works on killing cancer cells is by creating these double-strand breaks in the DNA. In a normal cell that has a normal DNA repair mechanism, when that happens, the normal cells that repair the DNA repair mechanism helps repair the damage that was done and helps the cell to survive. In cancer cells, particularly cancer cells who has a defective DNA repair mechanism, the damage is irreversible and it often leads to cancer cell death. This is particularly true for cancers that are defective in this homologous recombination pathway. And that's where the BRCA gene works, in that homologous recombination pathway. So cancer cells that have this deficient BRCA gene often cannot survive the damage produced by chemotherapy. So when we look at how many patients with ovarian cancer have this BRCA defect or BRCA mutation, how many patients have a defect in that homologous recombination pathway that includes the BRCA genes, we see that almost half of our patients with ovarian cancer have some form of defect in those genes, either because they inherited a gene defect from their parents or because their cancer inherently has a defective DNA repair mechanism because of how it came up, what we call a somatic mutation. So how do these PARP inhibitors work? So the PARP enzyme is actually another DNA repair enzyme. It helps repair not double-strand breaks, but single-strand breaks in the DNA. So the idea behind the drugs that target this enzyme is if you target the PARP enzyme and you prevent the cell from repairing those single-strand breaks, those single-strand breaks could then develop into double-strand breaks, and in cancer cells that are defective in the repair mechanism for the double-strand breaks, those cancer cells die off. And in fact, that's what we see, particularly in those patients who have homologous recombination. These drugs inhibit this PARP enzyme from doing its job. The cancer cells accumulate more and more double-strand breaks and end up dying. And that's where how these drugs work. Now, to talk a little bit about the concept of maintenance therapy. Unfortunately, like I talked about before, many patients with ovarian cancer suffer from relapses. And often these relapses become more and more frequent. The time between the end of chemotherapy and the next relapse start to shorten and shorten over time until finally the disease takes over. The idea behind maintenance therapy is to offer a drug after you finish chemotherapy that could extend the time before the next relapse happens. And that's where the role of PARP inhibitors comes in. These are 3 different clinical trials: the SOLO2 trial looking at Olaparib, the NOVA trial looking at Niraparib, and the Ariel-3 trial looking at Rucaparib. In these 3 trials, patients who had recurrent ovarian cancer, so the cancer had come back after it was first treated, those patients were treated with platinum-based chemotherapy, which is considered the standard of care for their treatment when the cancer comes back. And following their chemotherapy, these patients were randomized. So 2/3 of the patients got the investigational drug, 1/3 of the patients got a sugar pill or placebo. And in all 3 of these trials, there was a survival advantage to those patients who got the PARP inhibitor, meaning the likelihood of the cancer coming back, the likelihood of patients dying from their ovarian cancer was lower in that group that took the pill. This was particularly striking in patients who have BRCA mutations. Those patients who did not get the drug, those patients who took the placebo pill, on average had a relapse within 6 months of finishing their chemotherapy. Whereas if they took the PARP inhibitor, and all 3 of them seemed to work about the same, when they took the PARP inhibitor, those patients on average spent 2 years before the cancer came back. So that's quadrupling, tripling the time off of chemotherapy and the time before the cancer comes back. In fact, this was such an important advantage in terms of the benefit from the drug, that for the first time ever, we've been able to show that those patients who took the pill ended up actually living longer overall, almost a little bit over a year longer than those patients who did not take the medication. And please remember, many of those patients who ended up taking the sugar pill first were given the opportunity of taking the pill later on. So the advantage that was afforded by taking the pill early translated into a longer survival long. Now, when we saw this happening in the recurrent setting, obviously the next thought was, should we use it upfront? Should we use it upfront? Should we use it when patients are first diagnosed with cancer? And that turns out to be an even bigger and better, it turns out to afford a bigger difference and be probably a better option for a lot of these patients, meaning that it's probably better to use these drugs as early as possible in the cancer journey for patients with ovarian cancer, because that's where you get the biggest bang for your buck. So this is a clinical trial called the SOLO1 trial. It was presented in 2018 actually, and this is the reason why Olaparib was approved as a maintenance therapy following initial chemotherapy for patients with BRCA mutations who just finished their what we call first line or upfront chemotherapy. So in this trial, just like in the previous trials that I mentioned, patients with ovarian cancer who just finished their first round of chemotherapy were randomized to getting the drug. So 2/3 of the patients took this medication, and 1/3 took a sugar pill. These were all patients who had BRCA mutations either in the blood or in the tumor. And as you can see, the difference is very striking. In fact, more than half of the patients who were on the pill were alive without evidence of the cancer coming back at almost 5 years from when they started the trial. And this was a result we have never seen before, and the reason why we're so enthusiastic about these drugs, and probably one of the reasons we're improving outcomes for some of our patients. Again, this was looked at in the context of using a different drug, Niraparib, again in ovarian cancer patients. We see the same results, a tremendous difference in terms of how patients do. In this trial, the PRIMA trial looking at Niraparib, the investigators looked at really high-risk patients. So that's why the results look a little different. These are patients that were much worse off than the patients I presented in SOLO-1. These are patients with stage 4 cancer, patients who were left with a lot of cancer even once they finished chemotherapy. And even in those patients, the drugs really made a big difference, particularly in patients who had a BRCA mutation either in the cancer or in their blood. We've also looked at the combination of Olaparib with another drug, bevacizumab, which I mentioned before, and it seems like the combination is particularly useful in patients with BRCA mutations as well. And these are patients with advanced stage ovarian cancer who are getting Avastin already. You added the Olaparib drug to the Avastin. Unfortunately, in those patients who don't have a BRCA mutation, whether it's in their cancer or in the blood, patients who don't have this homologous recombination deficiency, it seems like the addition of Olaparib is not as advantageous. Okay, these drugs are so active that some people are actually looking at using these drugs instead of chemotherapy. Both Niraparib, Zejula, Rucaparib, and also Olaparib have been looked at as treatment options for patients with recurrent ovarian cancer. And it looks like they actually perform probably just as well, if not maybe better than chemotherapy. In this trial called the SOLO-3 trial, patients who had platinum-sensitive recurrent ovarian cancer who had BRCA mutations were randomized, so they were offered the option of being or randomized, or about 2/3 of the patients were given a pill with Olaparib instead of chemotherapy. The other third were offered chemotherapy, but not platinum-based chemotherapy. And in that trial, the Olaparib drug, the pill, performed even better than chemo. The outcomes were better for those patients who took the pill as opposed to the chemotherapy. The next few slides are going to deal a little bit with immune therapy, because this is another exciting topic in the treatment of ovarian cancer. Now, we now know that the immune system is extremely important in how the body handles cancer. We now know that there is such a thing as what we call the cancer immunity cycle. The body is constantly fighting with small cancers. And the immune system, the body's defenses, are really critical to fighting off cancer cells. That first starts off where the cancer cells die off and release these antigens. They could then trigger the immune system. The immune system could then start, when it recognizes that there is a cancer in the body, it launches its attack on the cancer using T cells. These T cells then go to where the cancers are and then launch their attack on the cancer, killing off the cancer cells. So as far as the different immune therapy options that we have, they center on a few different pathways. The first pathway is the ability of cancer cells to hide from the immune system. The immune system cells, these T cells that are designed to kill off the cancer cells, have to first recognize the cancer cells before they kill them. Some cancers, particularly melanomas and lung cancer, have this innate ability to tell the immune system, don't harm me. And we now know that at the heart of this are what we call checkpoint inhibitors, proteins that allow the cancer cells to tell the immune system, don't attack me. And if we target that interaction between the cancer cells and the T cells, we're able to fight off the cancer. The other way we've used the immune system against the cancer is by creating these aggressive T cells or aggressive immune cells that are designed to go after the cancer cells and kill them off. And finally, we've also looked at priming the immune system using vaccines, for example, to attack the cancer cells. The most commonly used immune therapies are these checkpoint inhibitors. Basically, these are drugs that are designed to block the cancer's ability to hide from the immune system. There's a number of them that have been approved over the past half a decade. The most commonly used one are pembrolizumab and nivolumab, which were approved 6 years ago now. They target this protein called PD-1. And then there are more drugs on the market now, atezolizumab, avelumab, and durvalumab that have been available for the past few years that target the PD-L1 blockade. This is an example of a patient with ovarian cancer who underwent treatment with nivolumab, which is a PD-1 inhibitor. And as you can see, just by using the immune system, the investigators were able to shrink down the cancer cells, shrink down the tumors, and get the cancer under control. Unfortunately, this is more the exception than the rule. It turns out that when we tried this approach using these PD-1s or PD-L1 inhibitors on patients with ovarian cancer, it's not very successful. At best, we can have maybe 1 out of every 5 patients respond to the treatment. It's not usually a very long-lived response. And so a lot of people have soured on using just these checkpoint inhibitors alone. We've used them in a variety of settings, including upfront. Unfortunately, unlike PARP inhibitors, we haven't been able to replicate the success we've seen with PARP inhibitors by using these checkpoint inhibitors or immune therapy along with chemo. So it did not end up working as well. We've also looked at combining these immune therapies with other non-chemotherapeutic options, like with bevacizumab, which targets the blood supply around the cancer. And for some patients, it does work, but not for all. And unfortunately, the responses are not great. We've also combined different immune therapies together. This is a clinical trial looking at ipilimumab, which is Yervoy. It targets an immune checkpoint called CTLA-4, and nivolumab, which targets PD-1. It seems like using the combination is better than using nivolumab alone, but unfortunately, the results are not great. In general, unfortunately, these responses are short-lived. As you can see, the median time before the patients progress is only 2 months in patients who took the nivolumab, which is the checkpoint inhibitor alone, as opposed to 4 months, not great responses. However, this may hold some promise for certain ovarian cancers. It seems like clear cell ovarian cancers really benefit from this combination more than anybody else. We still have to confirm this, but it may be a subset of patients who can benefit from this. And finally, this is a trial that was just presented this year at the European Society of Medical Oncology. This is looking at a chemo-free combination of a checkpoint inhibitor, durvalumab, which is a PD-1 inhibitor, Olaparib, one of our favorite PARP inhibitors, or favorite drugs, a PARP inhibitor, and bevacizumab. And it looks like the combination of all 3 drugs together offers patients with recurrent ovarian cancer meaningful responses. We still have to look at this in a more systematic way. This is a very early trial, and we still have to figure out if this is truly something that patients can tolerate. Often these drug combinations, particularly when you combine 2 or 3 drugs together, carry a lot of toxicities. So we still have to confirm that. The other options in terms of therapy for ovarian cancer that we're currently investigating are using the body's defense cells, the T cells. So this is the first one we're talking about is what we call tumor infiltrating lymphocytes or adoptive lymphocytes. So basically, the concept is you take a piece of the cancer out of the body. Inside this cancer are these T cells, these lymphocytes that are already embedded with the cancer. You allow them to grow, and you give them medication that basically puts them into overdrive. These cells multiply, kill off the cancer cells that are in that plate, and you can then figure out which one of these cultures has these lymphocytes that could recognize the cancer, grow them out, and you put them back into the body of the patient, allowing these cells that we know recognize the cancer and kill off the cancer cells to fight off the cancer. This is an example of a treatment regime using this tumor-infiltrating lymphocytes. So on the left, you'll notice a patient getting a tumor resected. That tumor is cut into little fragments. These fragments are then grown, allowing the lymphocytes to kill off the remaining cancer cells. When these lymphocytes are cultured, they're isolated to make sure they're isolated to, hold on, something happened to my presentation.
Looks like we might have lost your slides for a moment there.
Yeah, I'm going to try and pull them up again.
Okay.
Give me 1 second. There we go. Let me share again. Sorry about that. Can you hear me?
Yes, sir.
Yeah, I'm trying to see how I can share my slides. Hold on. I don't know where my... There we go. Let's share my screen. Do you see it? You see my screen?
It's black. So.
Okay. Now I can't share for some reason. I don't know what's happening. Oh, did that work? Can you see me?
That doesn't seem to have worked. We are going to try to pull up your slides on our end.
Okay. So maybe I can just do audio only for now.
That would be great.
So, okay, very good. So I'm sorry about that mishap. I don't know what happened. It just went black. Anyway, these lymphocytes are grown, and then patients are given chemotherapy to get rid of the or get rid of as much of the patient's own immune system cells that could compete with these lymphocytes. And then these lymphocytes are re-injected back into the new lymphocytes that are designed to attack the cancer are re-injected back into the patient. Another approach is to what we call chimeric antigen receptor T-cell therapy. It is very similar in terms of the concept. The difference here is when you get the T cells out of the patient's body, you reprogram them with a virus that contains a protein that's designed to recognize the cancer cell. So these T cells that are infected with this virus develop the ability to recognize the cancer cell. You then multiply these cancer cells and put them back into the body. The advantage here is you don't need to get a biopsy. You don't need to isolate specific T cells. You can take the patient's own T cells without trying to figure out which ones are going to work and just reprogram them. And this is now used for a lot of liquid cancers and being looked at for ovarian cancer. The final approach is what we call cytokine-induced killer cells. In this concept or in this model, we take immune cells called natural killer cells that are designed to fight off things like cancer cells. We, just like the CAR T cells, introduce a virus into the natural killer cells. These natural killer cells are activated so that they can fight off the cancer. They're multiplied, then injected back into the patient. These cancer cells, or these immune cells, recognize the cancer cells and then deliver the virus, which is like a stealth bomb, into the cancer cells. The virus multiplies and kills off the cancer cell. That's actively being looked at. We actually have a clinical trial in preparation looking at this approach to fight off ovarian cancer patients. And finally, there's a vaccine approach. In this model called dendritic cell vaccine model, cancer cells are removed from the patient. They are broken up into little pieces. They are exposed to immune cells called monocytes that develop into dendritic cells. These dendritic cells, once they get exposed to the virus, get activated and are then re-injected into the body where they're supposed to attack the cancer. And finally, this is just a pure vaccine model, just like we all are familiar with vaccines. This is what we call a Survivac vaccine. Ovarian cancer cells carry this protein on their surface called survivin, and it's unique to cancer cells. And it seems like we can prompt the body or prompt the immune system to recognize this survivin vaccine, this survivin protein, as foreign, thereby allowing the body's immune system to attack the cancer cells. So in this vaccine, you take fragments of a virus, mix them with the survivin protein, and then this new vaccine using virus fragments along with the survivin fragment gets injected into the patient. The patient's immune system recognizes survivin as foreign and then attacks the cancer. We conducted this clinical trial here at Stanford. We've actually had some notable successes with this approach, which led us to now help design a larger trial looking at comparing this approach to other more traditional treatments for ovarian cancer. Thank you. So in summary, like I said, PARP inhibitors are the biggest news we've had over the past few years. Immune therapy is still in development, but it is a very exciting, a avenue of research that we are conducting right now to see if we can better treat ovarian cancer. Thanks, everyone. I guess now we have some time for questions and answers.
Yeah, thank you so much, Dr. Karam, for sharing the information and updates in ovarian cancer treatment. We do have a few questions from the attendees today. The popular topic being in regards to low-grade ovarian cancer. If any of the studies or clinical trials you discussed apply to low-grade serous ovarian cancer?
Yeah, most of the trials that I discussed today mainly deal with high-grade serous cancers, the more common type of ovarian cancer. Low-grade serous cancer is unfortunately rare and not studied enough in my mind. The treatments for low-grade serous cancer don't center so much around, and the trials looking at low-grade serous cancer don't center so much around chemotherapy or chemotherapy that much anymore, because we know that it's in general not extremely helpful. We're looking at novel ways to fight off low-grade serous cancers using combination hormone therapy and other what we call checkpoint or targeted therapies that are inspired and derived from other cancer models that are hormonally responsive. The other clinical trials that are going on are looking at the combination of surgery and chemotherapy together, the concept of HIPEC, particularly because there are other cancer models that are like low-grade serous ovarian cancer, slow-growing, not so responsive to chemotherapy, that seem to do well with this surgical approach plus heated infusion chemotherapy. So we're certainly looking at that as one of the options for treating low-grade serous cancer.
Wonderful, thank you for that information. Where can attendees go if they do have ovarian cancer to apply for some of the clinical trials coming up that you mentioned?
Yeah, you know, that's a very good question, and unfortunately one that still frustrates a lot of physicians, a lot of patients. Often it's a little bit of the Wild West out there in terms of clinical trials. I often tell patients, start at your institution. If you're at a reputable academic institution, they should have a number of clinical trials available, so you can start there. Or if you are not at an academic center, I would start off with your local academic center in your region and go from there. You can, if you want, do your own research on clinicaltrials.gov. The National Cancer Institute has put in some effort into trying to make their clinical trial repository a little bit more user-friendly, and you can go to the website and try and look by using the various filters and your specific cancer into those search terms and looking for clinical trials that you think would apply to you. Unfortunately, you still have to contact those trial sites directly, because the clinicaltrials.gov website is not automatically updated and does not always have the actual information. So you still have to contact those sites directly. Also, another way to decide on clinical trials, a lot of our patients now get what we call next generation sequencing or a molecular analysis of their cancer. And often their reports will include clinical trials that apply to their particular cancer when it comes to the various gene mutations or molecular changes in their cancer.
Wonderful. Thank you so much for that. And also, I'd like to encourage all individuals to contact our cancer information and education specialists, Erica or Victoria at BACC. They can help find information as well in regards to clinical trials. So just being mindful of time, I don't want to go over. So thank you again, Dr. Karam, so much for joining us today and all the information you shared.
Thank you.